Good evening, all the participants. We'll be discussing neuroanatomical correlation of a cognitive assessment, and a very important topic. I propose to deal this topic in the following way. We'll briefly talk about cortical functional zones and cognitive networks that will help on our assessments. Also, we'll discuss about cognitive domains and principles of cognitive assessment. We'll address the issues of attention, language, visuospatial function, praxis, memory, agnosias, executive control function, and some disconnection syndromes. So this will be the scheme of presentation today, and we'll start by going to the neuroanatomy of cognition. And way back in 1800, the localization was a look at the historical aspects. They have numbered the whole brain area, and like 16 is hope, and 29 is order. Now, location of the organs, names, and numbers, it's in a haphazard way. So the science has developed subsequently, and now we know that we understand the schema like this. If it is the right cerebral hemisphere on left cerebral hemisphere, the neurobehavioral syndromes are numbered here 1, 2, 3, and 4. If you look at the frontal lobe dysfunction, distractibility, perseveration, lack of drive, impulsiveness are the common occurrences in frontal lobe dysfunction. The frontal lobes are the most advanced evolution of the brain part, and the humans only have frontal lobes, and when compared to other animals, that's what discriminates Homo sapiens from others. The second part is on the right side: hemispatial neglect, visuoconstructive disorders, topographic agnosia, and these are the visuospatial disorders on the right cerebral hemisphere. On the left side, you have the language associated disorders like aphasia, agraphia, alexia, apraxia, acalculia, finger nose, agnosia, right left disorientation, adjustment syndrome. If you look at the third, that is a posterior part in the occipitotemporal lobes. On the right side, predominantly prosopagnosia, and you have pure alexia, associative agnosias, color anomias. These are all visual recognition disorders. And in the center 4 is amnesia, that is the bilateral temporal lobes. And so to remember what are the neurobehavioral syndromes, and this is a scheme which has been popularized by Dr. Schindler. So most important, as you know, is the frontal lobes, and we have grown up looking at the Brodmann areas 4, 6, 44 AB, 18 C, and now the cortical type is there are association areas which are called the primary motor area and the secondary. What is the primary motor area? Unimodal motor area, heteromodal sensory cortex, and supramodal association cortex. So these are the association cortices. The brain is full of association cortex except for the primary sensory areas, which you will see in the coming slides. So the functional region, as far as primary motor cortex is motor, and the other areas which are depicted here, pars opercularis and 8, that is motor association cortex, these are premotors. And so this is very important for us to understand, because there are so many circuits that are coming from these areas. And dorsolateral prefrontal cortex is the most important heteromodal association area, and this is a prefrontal, and there is superior prefrontal cortex, inferior prefrontal cortex. All these come under heteromodal association areas, which I will talk. Pars triangularis is heteromodal and pars orbitalis is heteromodal. These are all prefrontal. These are ventrolateral and dorsolateral. And from these various areas, the networks spread to various other regions in the body. And the areas like lateral orbitofrontal cortex and medial orbitofrontal cortex, these are also orbitofrontal cortex abnormalities are seen whenever there is a disease in these areas. And 32 and 24 are medial frontal cortex and anterior cingulate. And only we will be talking about frontal lobe. The other areas we are not going to touch much, because frontal lobe is very, very important for all the students. We should know that. Now, this is the most important. The Meslam in 1985, this is really the father of the behavioral neurology. He has divided brain into four different types of neocortical functional zones. If you look at the primary motor and sensory areas, are these which are depicted in the blue. This is M1, and visual and auditory, somatosensory, and these are the primary motor and sensory areas. And surrounding these areas, you see the yellow thing. These are called unimodal association areas of motor and sensory cortices, and these are the areas. And you see the multimodal association cortices, anterior heteromodal association cortex and posterior heteromodal association cortex. These are depicted in somewhat pinkish color, and the limbic and paralimbic region is depicted here. See, the cingulate gyrus and the parahippocampal gyrus, and all these areas are, this is orbitofrontal region, this is the limbic and paralimbic region, and which is very, very important as far as emotions and other functions are concerned. We'll talk more about association areas. So there is an important area here that is called posterior heteromodal association area. Suppose if you look at the cycle, and you have to describe it, it has got two wheels and a seat and a handlebar, and that type of interpretation, the concept formation takes place in this heteromodal association areas. So these when there are concepts, and these are the areas which will provide us with the recognition faculty of our brain. So especially when we do cognitive testing, there are 5 cognitive domains, that is memory, language, attention, spatial cognition, and executive control function. And to this is added praxis also is important, but that's not given in this article. But these are the 5 cognitive domains which are usually tested in bedside testing. And there are connectivity. These various areas of the brain are connected: frontal, subcortical networks, and memory, language network, visuospatial, and intrinsic connectivity. So these are the various networks that are available, and these networks, it's not a particular area whose damage will cause a disease or a dysfunction. It is the malfunctioning of the networks that will give rise to dysfunction. So what are the most important subcortical circuits? There are 3 non-motor frontal subcortical circuits, and these are the inhibition, that is orbitofrontal circuit, and dysfunction of this circuit is inhibition, and disinhibition, perseveration, obsessive compulsive disease. These will result if there is any problem in this circuit of orbitofrontal circuit. Executive dorsolateral prefrontal and executive deficits and mood dysfunctions are all seen in this executive dorsolateral prefrontal. And motivation, anterior cingulate and medial frontal, apathy, akinetic mutism. So these are the 3 non-motor frontal subcortical circuits that are very important. And look at this picture. You see the orbitofrontal region, dorsolateral prefrontal, anterior cingulate. These are all this cortex, basal ganglia, thalamus, and limbic system, and all these are interconnected. The orbitofrontal region is connected to ventromedial caudate nucleus, and this in turn is got dorsomedial globus pallidus and ventral anterior nucleus of thalamus, and it's again gone back to this circuit. If this circuit dysfunction, and we have seen the problems, that is disinhibition. And dorsolateral prefrontal, dorsolateral caudate nucleus, and it comes to globus pallidus, and again it has connections to go back to the circuit. This circuit dysfunction will give rise to executive control dysfunction, and anterior cingulate and ventral putamen, prostromedial globus pallidus, and this also has connections with hippocampal formation, memory, and this circuit dysfunction will give rise to memory disturbances, apathy, akinetic mutism. All these things are the malfunctioning of the circuits. And the most important is Papez circuit. When Papez circuit, which has, you see, the limbic inputs as well as the sensory and limbic information is entering the entorhinal cortex, and from there the perforant pathway CA3, CA1, and the hippocampal formation, subiculum, and this is a mammillary body, and mammillary-thalamic tract, and anterior nucleus of thalamus, and posterior cingulate gyrus. So this is a circuit which reverberates and helps in memorizing things, in consolidating our memory. And but various disorders are no, they affect the circuit, and especially Alzheimer's disease affects the posterior cingulate and the entorhinal cortex, and neurofibrillary tangles are seen here. The CA1 is very susceptible to hypoxic damage. Thiamine deficiency will attack the mammillary bodies, and of course cerebrovascular accidents can attack any part of the brain and of the thalamus. And amyloid, you see, the amyloid deposition is in the posterior cingulate region, whereas neurofibrillary tangles are more in the entorhinal. So this is the Papez circuit which also get disturbed, and we'll have to assess the memory. So basically language is depicted here. It is a Wernicke's area, and the you see this is a Wernicke's area and this is a Broca's area, and you'll see what extra we are going to show is the anterior temporal lobe. In strokes we get Broca's aphasia, we got Wernicke's aphasia, and the arcuate fasciculus disruption will get conduction aphasia, and but anterior temporal lobe affliction will cause to semantic type of primary progressive aphasia or semantic dementia. That is usually not seen in strokes, but it is seen in degenerative disorders. So you see the motor and the central sulcus and the prefrontal region which are depicted here, the visual cortex, which are very, very important in cognition. And from visual cortex there are two pathways that go, the what pathway and the where pathway. And the where pathway is connected to the frontal eye field, and that's important because the eyes have to control the motor function. And the what pathway is extended up to the temporal lobe, and it is going up to Wernicke's area. So where pathway and what pathway will mediate the visuospatial function of humans. So, and apart from that we have very important networks which all the postgraduate students should learn. This is salience network, default network, executive control network, and we'll just slowly see about them, because for understanding our tests we should know what are these networks. Salience network is anterior cingulate, mid cingulate, dorsal anterior insula and frontal operculum. It is a body directed attention and behavior. It is a body state representation, body guided attention. This is cingulo-opercular network. The default mode network is ventral. Again, this is a cingulate, anterior cingulate gyrus, posterior cingulate, medial temporal lobe, and conceptualization, that is self-referential, experiential, the spontaneous thought. This default network is important for your self-awareness, and most of the dementia patients don't know that they have a problem. Whenever a dementia patient says that he has problem, we always say that, oh, you don't have any problem. Some other person has to say that he has a memory problem. Executive control network is a bilateral dorsolateral prefrontal cortex and inferior parietal lobule and precuneus. This is a fronto-parietal, and there is working memory, task switching, and executive control, which we'll have to see. Affective limbic network, that is the limbic area which is connected to, and also medial temporal lobe and amygdala are connected in this network, and this is motivated behaviors are observed in the controlled by this network. So just go by this network. This is salience network and default mode network, which I have already described. I'm just showing separately so that it should stick to your brain that there are intrinsic connectivity networks which you should know. Executive control network, frontoparietal region, and we'll see how to assess the executive control functions as and when we go after completion of this. So there is a dynamic network that's going on in the body. The default mode network is ventromedial prefrontal cortex and posterior cingulate cortex, and endogenously mediated self-referential mental activity is happening here. The salience network is anterior insula and anterior cingulate guts. This is a dynamic switching, that is sensory and limbic inputs are entering this, and it will come from switching means you have to task your one task to other task. And the third one is central executive network. It is dorsolateral prefrontal cortex to posterior, and this is the cingulate gyrus, exogenously driven, cognitively demanding mental activity. So these networks dysfunction will give rise to the cognitive dysfunction or dementia. So, as we said, the cinguloopercular system plays a central role in switching from an interoceptive stage to a goal-directed state. This system is hypothesized to initiate a dynamic switching between default mode and frontoparietal systems, that is the executive function. So, whenever you get a thought to do some work, and this network comes into picture. The model postulates a functional antagonism between the default mode and frontoparietal systems. So, detection of salient events is thought to be managed by the anterior insula. So, via integration of homostatic signals from the posterior insula and modulation by the anterior cingulate cortex. So, why you should know insula thoroughly, and what are the functions of insula and how it is affected in strokes, and what happens in the right insular strokes and left insular strokes, and what type of disturbances we get. So now we go to with this background, we'll go to the cognitive assessment, and the factors that affect usually are age, gender, educational level, normal versus disease state. And every student usually starts doing the MMSE mini mental status examination, which is grossly affected by the educational level. They often fail to note what education standard the patient has. Multiple dimensions to each cognitive domain. And if you look at the memory, there are various types of memory: episodic memory, semantic memory. Episodic memory is time locked. Semantic memory are facts and figures. Semantic memory is concentrated on frontotemporal regions. Episodic is in medial temporal region and dentate gyrus. Verbal is on the left temporal lobe and non-verbal on the right temporal lobe. So if you are checking at the memory, you have more domains and each multiple dimensions to each domain. That is memory domain, you have to test so many things. Similarly, many tests engage multiple domains. Like if you look at the clock drawing test, it tests abstraction, visuomotor function, language, executive function. By simply putting a circle, putting the numbers, longhand, shorthand, showing the time, the 4 marks are given, and that clock drawing, which is a simple test, if an individual is able to draw a clock, we can see that all the synapses that are connected are working perfectly in that individual. So what we do usually, these are the 6 headings which all the students should know. First of all, it is a hierarchical. That means attention should be tested first. Digit span, serial reversals or months of year, continuous performance or EA test. That means I'll show you again. Language, observed and semantic fluency. This is very important. That is letters starting with EF or the number of animals, and why we should know, and I'll show you a case also why we should do that. Comprehension, naming, repetition, reading and writing. These are the functions which the aphasia testing that is done in stroke is much more relevant in neurodegenerative disorders. Auditory verbal learning test for memory. The screening for remote memory with the current and historical events can be done. The visuospatial and perceptual testing can be done by constructions, 2-dimensional and 3-dimensional, or a search and cancellation tests. The praxis is done by upper extremity testing, miming, imitation, gesture comprehension, and executive function is done by mental control, frontal assessment battery, anti-saccades, abstractions, environmental dependency. So these 6 headings you should have in your mind that I'm going to do cognitive assessment, keeping in mind these 6 headings. And why and what are the levels of assessment? There are 4 levels, and first is screening, and there are tests which can be done in 5 minutes in the OPDs, and there are scales, that is mini mental status examination and MOCA, which will take 10 minutes or more. There is a detailed neuropsychological testing required whenever you require, that takes about 3 hours, and neurobehavioral status examination, it is unlimited and can target some specific areas. So the levels of assessment, what type of assessment you want for your patient, is determined by the presentation of the patient. So the question is, what are important principles of cognitive testing? The mental status examination is hierarchical. Absent responses can be interpreted as abnormal. It mostly involves pathognomonic cutoffs. Like you see, the MMSE has a cutoff. An abnormal test corresponds with a single impaired cognitive area. So A and C or all the above? What are the important principles? And I know it's a difficult general question, so you can answer. You can answer is all the above. And what are the important principles? The mental status examination is hierarchical. That's just attention you have to do first, and subsequently you can start doing other domains. Absent responses can be interpreted as abnormal, but that should not be the case, and you have to set. Suppose in one domain is not working properly or working properly, other domain may be affected. Like you can test by MMSE or a mocha test, but fluency, verbal fluency may be affected. It mostly involves pathognomic cutoffs. Yes, presently whatever scales are there, they are on quantitative assessment, not the qualitative assessment. It's often useful for us to see how the individual is doing the test. Abnormal test corresponds with a single impaired cognitive area. No, it is not one cognitive area. The abnormal test may represent more than one, as we have seen in clock drawing test. So these are the important principles which we'll again list out in the next slide. Specific cognitive testing, a brief screening, mental status examination should be available to us, so that some of the tests which you have to do, like MMSC and MOCA, you have to take permission. There are copyright issues for that, but that these scales are, we be careful whenever you are using for any research purposes. Of course, the ethical committee will always say that you have to take permission. Neuropsychological testing and neurobehavioral status examination is a very elaborate procedure that you don't require for all the cases. Tests that are brief and that should be available in public domain, and screening with pathognomic cutoffs may help, but a detailed searching is required if a clinical suspicion is more, and test each area with more than one task. So the individual, if there are 5 tests, he may do 1 or 2 or 3 well, but the other 2 may be abnormal. So each domain has to be tested with. So normal or abnormal, you can decide by if more than 3 out of the 4 tasks of that domain are abnormal. Context dependent, confounding variables, though, then you have to look at the sensory deficits, whether this individual has graphesthesia, stereognosis, any other sensory processing problems. And as I said, hierarchical, because attention impacts memory. So if attention is impaired, there is no point in doing a detailed memory examination. So first of all of you should know how to assess attention as a neurologist. So history suggests of mental status symptoms. Yes, and you see extended mental status examination, usually including a scale and a detailed neuropsychological testing subsequently. If mental status symptoms are not visible, then you do a screening test with any of the scales, like mini mental status examination or MOCA, and if there is an abnormality, you go, or if you still strongly suspect, also you should go to neuropsychological testing, which in detail we'll be discussing. So what is a 5-minute brief mental status examination, which is useful at the OPD level for all of us? You do a digit span and a orientation to time and place. These are the test response to physical and verbal stimuli. See, these tests should be done because there is a distractibility. If there is a distractibility and yet they are able to do these tests, then their attention is preserved. Name 6 common items to confrontation category, animals and word list, and then you can see you should have something like what I'm going to show now. You should have with you, and these common items and confrontation category, you should ask them to name the animals, the word list and everything. You should ask the colors. You can see the colors. We have made the objects, the actions, the reading, the writing, and you can have these things made and keep with you. For the DNB students, sometimes you may have to do a detailed examination. That time these things will be very helpful. The copy intersecting pentagons, perception, the clock drawing test, and very, very important. And lastly, you could observe interpersonal and emotional behaviors and insights, which will lead us to frontotemporal dementia or a variant of Alzheimer's disease. Then comes the mini mental status examination, MOOCA, etc. They are good for quantifying over time. Adequate test, retest, and interrater reliabilities are there. and well validated with alternate forms, but they are not specific for any focal deficit. There is a ceiling effect. Impaired, we do not assess all cognitive abilities in these tests. However, MOCA is recommended because it is derived from the Neurobehavior Status Exam at UCLA and includes more cognitive domains than MMSE. Nowadays, more than MMSE, everybody is doing the MOCA. The ceiling effect is the way, because if highly educated chap, though he has some cognitive assessment disability, may be able to perform the test very well. So now indications for neuropsychological testing. If there are mild deficits, you have to distinguish from the age and education norms. You differentiate dementia versus depression, and you have to determine extent of impairment of rehab program. Detailed and functional assessment as for capacity or competency determinations and medico-legal issues. So you have to decide for a person whether he is suitable for the job he is doing or not. And you have to be, depression has to be, that is pseudo dementia has to be differentiated. So these are very important issues. So let's have a question. Given the clinical problem, all are acceptable levels of cognitive assessment except one of these. Patient with cognitive features as part of neurological disorder, you do a neurobehavior status examination. Patients with progressive non-amnestic difficulty in cognition, you do a brief screening mental status examination. Medical legal assessment of a patient in motor vehicle accident, you have to do a neuropsychological testing. Follow-up of elderly person with memory complaint, you do a scales, MOCA scale or MMSE, mental status examination scale. And emergency patient with suspected delirium, a brief screening with mental status examination. Out of these, all are acceptable except one. Which one is that? Anyone can answer? You can chat. Anybody is answering this question? Okay. Yes. You can unmute and answer. Okay. If nobody is answering, then I'll tell you, with progressive non-amnestic difficulty, it is not brief screening of mental status examination. You have to go for a detailed examination. Patients with progressive non-amnestic difficulty, we cannot do only a brief screening. We have to go for a detailed examination. So in the cognitive assessment, first is a fundamental function, that is attention. And second, you go to the instrumental, that is memory, language, visuospatial, limb praxis and executive functions. We'll do one by one very quickly, and I'll tell you that you should equip yourself with at least 2 tests per this category so that you can quickly do in examination. Fundamental functions, arousal, whether that is you can get by your GCS scale, wakefulness, non-specific responsivity, and selective sustained shifting divided attention has to be assessed, and initiation, quantity, latency of onset, psychomotor speed, all have to be assessed. What we mean by mental control is a mixed fundamental executive concept that includes working memory. So if you look at the memory, this is memory is working memory and short-term memory and long-term memory. The working memory is perisylvian and located in the frontal lobes. So fundamental function testing, 2 examples for each area. You all know how to do digit span, and tell the patient, I am going to read a list of numbers, listen carefully, and when I am finished, repeat the same number after me. Present the digits in a normal tone of voice at a rate of 1 digit per second. Forward, repeat in the same order, reverse task, repeat in the backwards order. So digits forward and digits backward, reverse order. These are the 3 digits, 4 digits, 5 digits, 6 digits, 7 digits, and usually normal is up to 7 digits. Second test is a direction. Tell the patient, I am going to read you a long series of letters. Whenever you hear the letter A, indicate by tapping on the desk. Read the following letter list in a normal tone at a rate of 1 letter per second. L, T, P, E, A. So what are the omissions? What are the commissions? So these are the 2 important tests which you can do for attention. So what disorder is most characterized by abnormalities in digit span, serial reversals of months or year, and continuous performance like a test abnormality? So what is a disorder? Anybody can answer? Somebody can answer this question. See, cognitive neurology is a bit difficult to understand unless you participate. This class will be boring, and you will not. So let's try. Somebody can answer this. What disorder is most characterized by abnormalities in digit span, serial reversals, and continuous performance? So one of you has to answer this question. Hello, are you able to hear? Can somebody raise your hand? Hello, students, answer this question. This is a problem which you commonly see in your ICUs. What is it called? Where you have problems in attention and digit span is not commonly done. That is attention difficulty. That is in delirium. Answer is delirium. So intermittently you get questions. Please concentrate and try and answer. The attention can be done, the frontal lobe testing usually, that is trail making test A and B will take 5 to 10 minutes, digit span forward, digit span backward, sequential operation series like months of the year backwards, 3 per task, and Stroop test, which I didn't share here, it takes 7 to 10 minutes. So these are the tests which are for the attention. So you should remember that you have to do these tests before you indulge in a detailed assessment. So next we'll go to, for functional we have finished. I'll go to language, and as language you have to look for the fluency and comprehension. That is, you have to look for auditory comprehension as well as visual comprehension. And repetition is a very important aspect of the disorder, the testing of aphasia. Naming, point to 4 items and the name. Reading, read brief sentence, and writing, read brief sentence also. You have to write. So we have made a small program like writing. Writing, we have shown that please write the names of the objects which we have made drawn, write the serial numbers from 11 to 20. So that's how you do the writing test. We have objectives of sentence comprehensions also. So you have to have sentence, the lion dash only when it is hungry, hunts or bends. So he has to put a appropriate word in the sentence comprehension. So these comprehensions are very important, and you have to show the repetition. Of course, you have to repetition should be from a small word to a sentence and a phrase which has got about 3 to 5 words in that. That is, often we English we use no ifs, ands or buts, but that's not possible for Indian people. So you have to have your Hindi version of it. Naming, point 4 items and name, and I showed you a kite, a cycle, a chap who is a bow, and ask them to read, and read brief sentences and write brief sentences, and you can do calculation also, simple calculations. So fluency, this is what I wanted to stress, because words per minute, fluent is more than 100 words, non-fluent is less than 50 words. The phrase length, almost 6 words per phrase, is a good fluent. But if it is 1 word or 1 to 2 words per phrase, that is a not a satisfactory. It's called non-fluent. Non-fluent is a Broca's aphasia. Agrammatism, is it present or absent? And if it is, agrammatism is present but telegraphic. And content is empty, paraphasic, that is fluent aphasia or Wernicke's aphasia. High content words and non-fluent, because the comprehension is preserved here. Effortful and hesitant and speech, these both are normal in Wernicke's aphasia, but in Broca's, effortful, hesitant, dysarthric and dysprosody, these are the characteristics of anterior aphasia. So we have this aphasia or this language fluency test, which is done in neurodegeneration, is different from what we do in strokes. Mind that. Question: what disorder is mostly characterized by abnormalities in observed fluency, confrontational naming, repetition, reading and writing? What disorder is? Dr. Reddy, you can, somebody can answer this question. Dr. Kiran Reddy, you can, yes, you can unmute and answer. Yeah, yes. That's good. That's good. That's not, that encourages me. MC, in fact, okay, we are talking of degenerative disorders. We are talking of degenerative disorders. So this is Broca's aphasia, that's correct, but primary progressive aphasia also to be. In degenerative disorders, it is primary progressive aphasia. So you have two. If you are talking in degenerative disorders, it's BPA. If you're talking in strokes, MCA, it is Broca's aphasia, right? This is a person, this is a Henry Molaison, who undergone bitemporal lobectomy. He could not lay any new information, that is, anterograde learning is defective. He could not incorporate new knowledge, and he had a problem in delayed recall. So this is a characteristic finding, delayed. So anterograde learning and delayed recall are important features of Alzheimer's disease. The cognitive domain language, the Boston naming test, 15 item short form, takes 3 to 5 minutes. Oral word associations, 5. Semantic category fluency, 5 minutes. That means you have to ask them, tell the number of animals you can in 1 minute time, or tell all the words that start with F in 1 minute, so that you can do the semantic category fluency. So that is a part of the language which we have done. Now we go into visuospatial perception function, very exciting. And to do this test, you have to know constructions, two-dimensional and three-dimensional, and you have to do a spatial search and cancellation, digit cancellation test, and you have to perceptual organization, which will tell you how to do that, and special perceptual areas like face recognition, like persopognosia, agnosias will come into this. So we have already seen in the first slide that the posterior part, and these are the a clinical approach. You have to make them do a two-dimensional and three-dimensional figures to understand what problems our visuospatial perception is causing. And you have to make them draw a clock, which is very important. A clock drawing test bedside is very useful. If they are able to make a good clock, then all these synapses that are coming into play are working perfect. And you can ask them to circle these dots, and they should do it correctly. That is again, this is what are the things which are embedded in this. Is there a bangan here, there is a teacup here, there is an umbrella, there is a saw. They should be able to abstract all these items out. And various modes of the face set, visual perception of the modes, and can be observed or not observed. So what disorder is mostly characterized by abnormalities in two-dimension, three-dimension constructions, and digit cancellation test abnormality, and figure ground discrimination. So what are these visual perception abnormality disorder which you can think of? Visual perception abnormalities. In which disease? It's a bit tough for you. It is posterior cortical atrophy and Balinit syndrome. So if you have posterior cortical atrophy, a type of, yes, you have said that. Yes, yeah, whatever you're doing. Posterior parietal atrophy, the posterior cortical atrophy. Parietal, I mean, that's okay. That is the posterior heteromodal association area, inferior parietal lobule, and surrounding areas. And of course, optic ataxia, apraxia, simultagnosia is Balinit syndrome. So that takes us to praxis. And what is praxis, and what is the definition of praxis? The loss of the ability to perform purposeful skilled movements when this deficit cannot be explained by motor deficits like weakness, sensory defects, movement disorders like tremor, ataxia, chorea, balismus, etc., or certain cognitive disorders, poor comprehension. There are 5 major types of apraxia, and each are defined by the task demands and types of errors. So apraxia is usually neglected by all the students, but It is frequently asked in vivas also. And what are these 5 major types of apraxia? Anybody? Apraxia? Of course, it is everybody knows what is apraxia and how to test for it and how to elicit history for apraxia, because whenever you are working up a case, you should know how to take history also and how to examine these patients. So what are the types of apraxia? You can say upper limb apraxia only, you can tell. Okay, so let's go on to the next. So the limb-kinetic apraxia, ideomotor, dissociation and conduction, ideational and conceptual. So these are the types of limb apraxia, and all the DNB students, mind you, this question is often asked in exam. So you should know in detail about the types of limb apraxia and how to examine them. So you can look at this. This is a visual input, and this is a left cerebral hemisphere. This is a right hemisphere. Right hemisphere. You see how this is working. Visual input, object units. There are action semantics which are stored in the unimodal association areas and multimodal association areas. There are movement representations, or the sketchpad is written in this area, or the software is the programs are stored here. The lexical semantics are stored, which will be activated by the auditory input. And from these, what will happen? They go to premotor cortex on the ipsilateral side. They cross the corpus callosum and go to the premotor cortex on the, that is supplementary motor area on the right side. And so from motor cortex, the impulses go to the spinal cord to perform an act. So this is the praxis circuit, which you should know. From the right side, and it goes to the left, from the left side goes to the right side, and the impulse. So this circuit, everybody should remember, there are action semantics here, movement representations, lexical semantics, which are activated by auditory input and visual input, visual gesture input also. And sometimes you have to do all these tests to see whether there is any abnormality in the praxis. So ideomotor apraxia, upper limb, brush teeth, flip coin, salute, blow out match, lick lips, lower limb, kick ball, and you draw a figure of 8, you bow and take a boxer stance. So these are all the నాన్నగారు నేను మళ్ళీ మాట్లాడుతున్నాను క్లాస్లో. Okay, whole body. And so these are tested for ideomotor apraxias. Very sorry for that. So ideomotor is a fail to pantomime and imitate. That is ideomotor. There are 2 types, parietal and disconnection type. Parietal may not understand the gesture also. Even if you show how to do it, they will not be able to do it. And disconnection types, they understand the gestures and they will be able to do that. But on their own, they will not be able to do it. Impaired language comprehension, this is dissociation. Impaired loss of meaning, that is seen in dementia. Impaired decreased dexterity in limb-kinetic. They will not be able to handle things. They will not be able to do dexterity of the fingers, and hand is lost. So this is the idea. The what localization is most characterized by abnormalities in upper extremity miming, that is pantomime, imitation, and possibly gesture comprehension. What is the localization? Where is this? Where is the problem? I have shown you the circuit. I have shown you where the semantics, the software, the programs are stored, and they reach the supplementary motor area on the left side first and then go to the right side. So which is the area which is important for praxis? Which is the area? I'll show you the summary of the praxis, but try and tell something. Which area in the brain is important for praxis? Nobody is answering. Which area is very important for the praxis? Okay, and it is left parietal lobe, madam. It's left parietal lobe. And that much you should know. Left parietal lobe is very important. Can be seen with bilateral lesions, but worse on the left side lesions. And this type of problem is frequently encountered in corticobasal syndrome. Okay, right. So what is the odd thing here in this? All ideomotor apraxia patients fail to mime. All ideomotor apraxia patients can imitate. Ideomotor apraxia disconnection subtype differs from parietal subtype in understanding the gestures. Dissociative apraxia is a language problem. Conceptual apraxia is common in dementia. So out of these, somebody is raising hand. Yeah, that's it. Let's see what you have. D. Dissociative apraxia. Okay, is a language problem. So, ideomotor apraxia patients can imitate. Can they imitate? I think the answer is debatable, but what we know is all ideomotor apraxia patients can imitate is a wrong question, a wrong answer. So that should be there. So you see parietal, inferior parietal lobe, and callosal. So these are the lesions which are seen in the arcuate fasciculus and the inferior parietal lobule, and you got a motor and sensory changes and poor pantomime in the parietal, and callosal has body part observation and recognition is possible, and the lesion is in the callosal corpus callosum. So constructional apraxia, there is a visual stimulus, spatial working memory, and motor output is not there because there is a problem here. Spatial working memory, that is surrounding the visual area, that is area 17 or 80. There is a visual association area, that is unimodal association area. If there is a problem, then you have got a constructional apraxia. If the mental representation is preserved, then the motor output is possible. If this is gone, you can see that the motor output will be bad. So constructional apraxia is usually a right side, a right hemispherical problem. So apraxia summary, you can say that you will start with A. You can see the A's are lexical semantics, A, object recognition units, they are defective, and see these are coming from the posterior aspect of the left hemisphere, left cerebral hemisphere, and I showed you also this is the auditory input and the gesture input and the vision input, and the movement formulas and action tool semantics are preserved there, and they are carried to the premotor cortex, that is supplementary motor area, on the left side first and right side then. So you have a dissociation apraxia when there is a disruption in A here, and you got a conceptual apraxia when there is a problem in B, and that is action tools are disturbed, and there is a ideomotor apraxia when there is a problem between movement formula and the supplementary motor area, and D is a limb-kinetic apraxia. You got three positions: motor cortex abnormality, connections between motor cortex and supplementary motor area, and conduction apraxia is when it is not reaching the movement formula software in the left parietal lobe. So these are the apraxia summaries which I thought I will sensitize you, and you will have to read for yourself. So the spatial cognition, you can do a cube copy test, cancellation test, digit cancellation test, line bisection test. All these tests will take only a small 1 to 2 minutes time. Right. So now we'll come to the memory part of the presentation, and memory is very important. You see the long-term memory, the short-term memory, sensory memory, working memory. See the memory as understood by the yes. What is it? Sir, optic apraxia and optic aphasia coexist. Yes, they do. Optic apraxia, optic aphasia is what? Optic aphasia, I don't know. What is optic aphasia? Optic apraxia, yes. Optic aphasia, I have not. No. You can tell. Sorry, typo. What is that?
When someone has trouble understanding the object, but when I tell them, then they can actually describe and then understand. They can't feel it. So we have prosopagnosia, we have optic aphasia also. So object meaning is impaired. So with optic aphasia, we get CBT variants too.
So that means the visual comprehension part you are telling. The visual comprehension part, which is the what pathway? From the visual association cortex, it's going temporal lobe, that Wernicke's area. So that one, okay. So let's go to the
Thank
memory.
you.
Yeah, long-term memory. You got declarative. It is episodic memory and semantic memory. These are the two things. Episodic memory impairment is the characteristic feature of Alzheimer's disease, and mostly semantic memory can be disturbed here also, but it's more often in frontotemporal dementia. World knowledge, object knowledge, language knowledge, conceptual priming, both are affected in Alzheimer's disease, but frontotemporal dementia has more of semantic memory problems, and episodic memory problems are more with the Alzheimer's disease. They are non-declarative memory, that is implicit. This is procedural memory of skills and motor and cognitive, and priming and conditioned response, classical conditioning and habituation and sensitization. This doesn't require any active participation of the temporal lobe or medial temporal lobe. So these are very, now the short-term memory or working memory short, this is used as differently by psychiatrists and neurologists. So our short-term memory is the recent memory, and that is episodic memory. When you had your breakfast, where did you go last week? These are time locked, whereas the facts of semantic memory are hard facts, and there are various types of semantic memory, and we can talk about them in the subsequent classes, and this is not the class. So memory testing, immediate registration, same as attention. Delayed recall is a very important test which you have to do, and auditory verbal learning test has got about 15 nouns, 15 words, which are presented once. Then the individual has to tell whatever he remembers, and like that 5 times they are presented, and gradually his learning capacity increases, that is called anterograde learning. Then a test B is given, which is different 15 words, and he also learns, and then he rests and does other tasks, and after about 30 minutes to below 30 minutes, 5 to 30 minutes, he again asked to recollect what. So delayed recall is one of the important aspects. Recognition and retrieval. Recognition part of the word list, and visual figure recognition, that is Benton's visual memory test, and you draw three triangle, a square and a circle on a paper, and just show him for a second and turn it and ask him to draw again. So remote memory, 3 current events and 3 major historical events you can check. So there are various ways of memory testing, and what disorder is mostly characterized by predominant abnormalities in AVLT test and delayed recall, and this everybody can answer, I think. What test, what disease is characterized by abnormalities in audio? I mean, that is race auditory verbal learning test and delayed recall. And everybody can answer this, I think. This is a simple question. Yes, right. Who has answered? Anterograde amnesia? Sonal, don't answer. Let students answer. You don't answer.
Okay, sir. Yeah.
Let students answer. What is a disease which you commonly see? That is Alzheimer's disease. See, what you see is Alzheimer's disease. These are the problems in Alzheimer's disease. Anterograde learning, and that is disturbed. You can do a paired associate learning test, and there are so many other verbal. But as I said in the brief screening test, at least 6 nouns you give and ask him to remember. This is Alzheimer's disease. So delayed recall is most sensitive to memory deficit. Recall distinguishes storage and retrieval deficits. So you have to know what is the encoding, what is the storage, what is the retrieval problems. Montreal Cognitive Assessment, there is a 5-word list, and they are given 2 learning trials, and delayed recall is a quantitative test, and category queuing and multiple choice qualitative. So one of the important things is, whenever they are not able to recall, you give a cue. Queuing will help in certain conditions, and we'll see what are those conditions. So the 3-step process, verbal episodic memory, this word list learning has got 3 stages. Encoding, the processing of information, that X, Y, Z, they are these are the words, whatever words you give, you have to ask him to repeat these. And we have this in MMSE also. Registration we do with 3 words. and he has to retain this information over time. We'll tell them in MMSE that we'll come back and ask you again, and so you can ask questions. I am your student, sir. It's so informative lecture, sir. Oh, okay, okay, thank you. Uh, so retrieval, access information. What were the three words? Now there is a defect in storage, then he will not be able to recall at all. If he is able to retrieve with queuing, it is a different, it is a retrieval problem, which is a subcortical dementia. So encoding, storage and retrieval are the three aspects. So encoding deficit is seen in impaired attention and working memory problems. These are seen in depression, anxiety, medication side effects, delirium, sleep apnea. So if they are not able to encode what you are telling, then these are the things which you have to consider. Retrieval deficit, that is aging, mild cognitive impairment, depression, and also the fronto-subcortical disorders, Parkinson's disease, cerebrovascular disease, these are retrieval deficits. These subcortical dementias improve by queuing. The storage deficit, this is amnestic, MCI, Alzheimer's disease, there they are not able to encode and store the material at all. So that is the three aspects of verbal episodic memory. You should remember: encoding and retrieval deficits. So you see that here what you are seeing is this dentate gyrus and the procebiculum CA1, CA2, CA3, CA4 dentate gyrus and the entorhinal cortex. This anatomy is very, very important. This is thalamus. So now why it is important is this is where your consolidation of the memory takes place, and it is a key for the remote recent memory. So the perirenal parahippocampal cortex, entorhinal cortex, dentate gyrus, CA3 region, CA1 region of hippocampus, procebiculum, and this is the circuit that is disturbed. So the sensory specific multimodal association and limbic cortices are sending the impulses, and if they are stored here, their familiarity is established and recollection is because of this circuit. So the motor or declarative implicit memory doesn't require this circuit. That is the whatever we have seen, the non-declarative memory, implicit memory, that procedural memory doesn't require this circuit. So you can do by ray auditory verbal learning test is a most specific. What Sherrod word list learning, Hopkins verbal learning test, which they quoted. But what I do is a paired associate learning test, which is also very good to document anterograde learning. So this is very important. That's about the memory. Now agnosias, and these are the agnosias which are very important to understand. Agnosia is again, could you please tell what lesion can predominantly cause word retrieval and not repetition alone? So this is a degenerative retrieval problems are subcortical usually. So Parkinson's disease, Huntington's disease and vascular dementias will cause retrieval problems. Repetition is a problem, not repetition. Repetition is a problem with usually transcortical aphasias and transcortical sensory and transcortical motor aphasia, where repetition is preserved, whereas Broca's aphasia and Wernicke's aphasia, repetition is not. So I feel that it is mostly the subcortical pathologies that will affect the problems. So the agnosias is impaired awareness or recognition, and their sensory visual sensation, auditory sensation, tactile sensation, all these object recognition, facial recognition, prosopagnosia, linguistic or non-linguistic, and graphesthesia, cortical sensory loss, that is a tactile. So this test we do usually, but we don't correlate with agnosia. This is a tactile graphesthesia which we usually do for cortical sensory testing. And impaired prosopagnosia is impaired recognition of familiar faces. You also should have in your some photographs which you can show to the patients and identify and test for prosopagnosia. Sometimes this is usually now you can say that you can keep the photo of Mahatma Gandhi or Indira Gandhi, and which I can show and Lal Bahadur Shastri or Vajpayee, then they should be able to and identify them. So impaired recognition of familiar faces is a problem in the fusiform face area, occipital temporal, usually seen with large right hemisphere or bilateral lesions in this area. And there are two types, apperceptive and associative types. And developmental prosopagnosia is also known because they can't identify their own face. And in Capgras syndrome, spouse as an imposter, they think that. So this is another problem which is often encountered in dementia cases. And if you look at the fusiform face area, which is in the green, and the striate cortex, which are very close, and this is where the problem of prosopagnosia is there. Anosognosia, and anosognosia is usually called unawareness of a paralyzed limb. That's how it has come, but now it is applied for all the clinical constructs of for unawareness of deficits. It's measured by clinical judgment or discrepancy scores. In Alzheimer's disease patients, it's highly variable, but clinically significant. We have to look for anosognosia, and it may be associated with apathy and frontal executive deficits, and there may be dorsolateral prefrontal deficit in perfusion in cases of strokes that also can cause anosognosia. So again, the procerebellum is an area in Alzheimer's disease where a lot of neurofibrillary tangles accumulate and cause anosognosia. So anosognosia is an important aspect, and this diagram I request all the students to memorize and learn about this diagram very much. So anosognosia, they are feedback projections from the prosubiculum, which is PRO here, to the entorhinal cortex and output to the diencephalic structures, that is mammillary body, anterior nucleus of the thalamus, and these are the circuits of episodic memory. So the connections of prosubiculum to the amygdala and anterior cingulate gyrus are predatorily implicated in self-awareness. So these are, if self-awareness means insight, and they should have insight of their body, if there is any problem in this area, and they will lose the self-awareness. That is prosubiculum, which I have shown you earlier, is a very, very important area for anosognosia. Right. So they also showed that it is the medial temporal lobe atrophy that is also responsible, but these are functional studies of the Alzheimer's disease cases. Now we'll come to executive control function testing, and mental control, digits backward, serial subtractions, and frontal assessment battery tasks, that is verbal fluency, S words, motor series programming, Luria alternating programs, abstraction with idioms and proverbs, antisaccades for response inhibition, environmental dependency science, in addition to grasp, preservation, utilization or imitation behavior, closing in phenomena. See, the antisaccades is a very interesting test. You have to look at a dot, and some distraction will be happening on the one side of the dot, that is on the right or left. You are supposed to look at the other side, and you should not get distracted. So antisaccades, and you have to prevent that saccadic movement. And this is for trial test, which most of you are done. If you don't know, you have to learn the trial test. This is trials A, there is a trial B also. 1 is connected to A, and A is connected to 2, 2 is connected to B, 3 is connected to C, C is connected to 4, 4 is connected to D. This is the trial basis. And sometimes the completion of task is important, sometimes the timing is done. So this is where the timing is shown, how much time he has taken to finish this task. The trial B is a very elaborate one, and you can see the slap, the face, and the cut test, and this also can be usually done at the bedside. So now verbal fluency testing, phonemic letters, that is letters D or S or F, sensitive to frontal lobe lesions, stroke, trauma. Normally they can generate about 10 to 11 letters per 11 words per minute. And semantic category, you ask them to tell animals and grocery items. It is also sensitive to frontal and temporal lobe function, especially in Alzheimer's disease. Normally 17 to 18 per minute, more sensitive to age and education. It reflects the integrity of the defect motor network, semantic processing networks. So this is the posterior cingulate, the medial temporal lobe, anterior and lateral temporal regions, if they are intact, the semantic category. So semantic dementia is anterior temporal lobe, right? That's the message you should take. And you can see the normal controls. Semantic is better than phonemic. In MCI, decrease semantic than phone, and in AD, both semantic and phonemic are decreased. You see, this is the normal controls. But as you see, the MCI both are decreasing, and in AD both decreases. So as I said earlier, the semantic is more affected in frontotemporal in my experience than in the Alzheimer's disease. So this is a verbal fluency. Usually animals names are written, about 19, one he had repeated, and the words, there is a word which we should not pronounce here, but that indicates disinhibition. So that's why F word is chosen, so that whether he utters that word, which I cannot utter, if he writes that, that means he has got disinhibition. So memory deficit is 0 to 1, correct and delayed recall, not helped by category clue, and not aware of memory deficit. That is characteristic of Alzheimer's disease. Semantic fluency relatively impaired versus category fluency. So 12 animals and 12 F words. Impaired cube copy, naming, clock drawing, etc. So this is the cognitive profile of Alzheimer's disease. So utilization behavior, you can see if this individual is doing that, this patient also will do same thing, and if he is doing this also will do the same thing. And utilization behavior, if there he sees some bed sheet, he will start wearing it. If somebody is doing namaste, the patient also will start doing namaste. And so this is utilization behavior, whatever is available they start using that. You look at this man, 70-year-old woman with 3 years history of cognitive symptoms, and that is following the colon surgery. 1 year ago, look at the MMSE, 28 out of 30, only recall -2, and mini mental 45 out of 50. Verbal fluency, look at animals 19, F words 22, clock full marks. Now after 1 year, the MMSE is not showing much difference. It is 27 by 30, the -3 recall, and the MMX also is not showing. But look at the animals, they have gone down, animal, and F words are still doing better. Clock also has slight deterioration. That means the animal fluency, the category fluency is very, very important. Similarly, another man with 2 years history of short-term memory changes, loss of empathy, impulsivity, catastrophic financial decision, that means behavioral abnormalities. The MOCA is okay, that's not telling us anything. But you look at the F words, they have gone down. So MRI brain has shown marked left temporal and frontal atrophy. So this simple test is very, very important, the verbal fluency test. What localization is most characterized by abnormalities in mental control, frontal assessment battery, anti-saccades, abstractions, and shows environmental dependency. What is that disease? What is the disease which will... I am waiting for the answer. Waiting for the answer. What disease will cause this? It is very easy. No, there are only 3 primary dementias all the DNB students are supposed to learn. That is dementia with Lewy body, Alzheimer's disease, and frontotemporal dementia. So this is frontotemporal lobe and dorsolateral function. That is where you have all these problems. So copying, that is the visual constructional praxis. Parietal lobes play different roles. Right hemisphere, the external form, that is gestalt. You show some gesture, they will, but left hemisphere has internal details problems. So you can differentiate Alzheimer's disease from frontotemporal dementia by saying that in Alzheimer's disease, performance is correlated with right parietal volume, spatial perception, and spatial planning tests. In behavioral variant frontotemporal dementia, performance is correlated with dorsolateral prefrontal cortex volume and spatial working memory and spatial attention tests. So you should, at bedside, when a patient presents to us, we should be able to differentiate between Alzheimer's disease and frontotemporal dementia. You can see the pentagon, that MMSE is 13 to 18, and DLB is 13 to 22. This is the pentagon. The pentagon copying is more impaired in dementia with Lewy bodies than in Alzheimer's disease. So this is a clue that the pentagon copying is more disrupted in this. So what visual dominant executive control function? Anti-saccades will take 3 minutes. Similarity subtest you can do 3 to 5 minutes. Frontal assessment battery 10, and all of you should do clock drawing test. Clock drawing test is a simple, easiest test which you can perform. Lastly, we'll talk about disconnection syndromes, and I'll tell you a case who is a 48 years old male presented with 5 months history of short-term memory and word finding difficulties. MMSE is 22 by 30. Attention, executive, construction, and deficits are there. And praxis and left-right orientation is intact. He was disfluent, hypophonic speech, masked faces, and deep tangent jerks are left more than right. They are brisk. Left side Babinski sign, equivalent, that is equivocal on the right side. So what is this case? And you see I'll show you the MRI also in this. And this has got these many problems, and not going to the circle is not done correctly, and there is a perseveration, and you can see this, he is not able to do this task properly, his clock is very bad, and he is not able to do the two-dimensional, three-dimensional pictures, and this thing is also two-dimensional, also is not able to do. Over next 3 months, there is a rapid decline in gait and functional abilities. He developed resting apraxia, and he used to bump into things on the left side. And he had on examination oculomotor apraxia, lid opening apraxia, color anomia, constructional apraxia, adjustment syndrome, acalyclia, dysgraphia, left-right confusion, and finger agnosia. All these are present in this case. And you can see he is not able to write your name left hand, right hand. You can see Bill is his name, and but one hand he can write, but other hand he cannot. And draw a circle. This is a circle. Draw a triangle. Write a sentence. Bisect a line. Copy this diagram. And he is not able to do any of these things. That means he's got a severe problem in construction. And see, so now we have seen this inferior parietal lobule and how this is connected to the right and left. The motor and sensory inputs from left and right crisscross, and they have to be, the corpus callosum has to be normal for all these circuits have to function. This is the arcuate fasciculus from inferior parietal lobule. So auditory and somatosensory inputs are coming in, and vision is coming into the inferior parietal lobe. That's why, and from here, this is the inferior parietal lobe on the left side, premotor. And so what's important is in this disorder, any disconnection will give rise to various deficits like sensory neglect, tactile agnosia, apraxia, agraphia, grasp reflex. These are all seen on the left side. And why? Because his MRI has shown very rapidly progressive white matter disease, and this is the flare MRI. Initially you can see the white matter abnormality that is developing, and you can see the corpus callosum which is so much wasted, atrophied. And 1 month post video of that is shown, 2 months post video is shown extensive white matter. The gray matter is not involved. The gray matter signs are not there. In this, it's only disconnection that is happening. In the gray matter signs, the seizures are not there. Memory impairment is not much, but functional deficits are more. So the brain PET has shown marked decreased hypermetabolism, right more than left. Brain biopsy is non-diagnostic. He died 14 months after the onset. The post-mortem is consistent with leukodystrophy. Gray matter was totally unaffected. Multiple syndromes or higher cortical dysfunction due to white matter disconnection. So we have seen many disconnection syndromes. One more is alien hand syndrome. It is described in 1972 of Brion, and in patients with corpus callosum tumors. Denial of ownership of the hand, feeling of foreignness and autonomous activity, interhemispheric transcallosal sensory motor disconnection, which we have seen the connections in the previous slide, And there may be associated tactile anomia, limb apraxia, grasp reflex, bimanual discoordination, myoclonus, intermanual conflicts, etc. And it is a very characteristic find in corticobasal syndrome. Alien hand syndrome is a major disconnection syndrome, disconnection of a limb from supplementary motor areas, which is seen. You can see the voluntary action, you can see supplementary motor area is getting activated here. Whereas in alien hand, there is no activation in the supplementary motor area in this functional MRI. So this is a alien hand syndrome, which is very Basal syndrome also has this is alien hand syndrome, and this also has shown the structural brain imaging defect in the parietal lobe, and so the extensive defect. This is the hippocampus. This is the reason where pericingulate gyrus. So Allen hand syndrome is a supplementary motor area problem, which you can see in this also and in this also. That defect will give rise to Allen hand syndrome. So summary cognitive testing. Primary aim of cognitive testing is to provide objective data regarding real life functioning. What is the problem? The cognitive testing can be done in a brief systematic way, and it facilitates differential diagnosis in relation to brain, and eventually should be more routine and more focused on brain fitness. So we have to learn most of the things. So what we did is we learned about attention, that we should do digit span, serial reversals of months of a year, continuous performance A test which I showed you, and we have to look at the semantic fluency and the category fluency, comprehension, naming, repetition, the language, and AVLT, that is for the memory. Anterograde learning is defective in the first thing to disappear in Alzheimer's disease and episodic memory impairment. Visuospatial, and these are the 2-dimension, 3-dimension constructions and digit cancellation tests. Praxis with miming, imitation, gesture comprehension, and executive control function, mental control, anti-saccades, abstractions, environmental dependency. We have seen that clock drawing and trial test. So all these will sum up the cognitive assessment for the DNB students who have to do these tests very much. So I think I have finished this time. We'll take up the dementia topics slowly one by one. Rapidly progressive dementias, Alzheimer's disease. We have to learn so much in this cognitive neurology field. If there are any questions, you can ask. Any questions from anybody? So I think that everybody must have understood a bit of it, but it's a difficult science. You have to keep reading, and uh, uh, do read whatever topics we have studied today. With that, I think I'll say good night to all of you and enjoy the weekend. Next week we'll meet again. Vishnu Vardhan, behavioral dependency, frontal lobe problem only. What do you want to tell? Are you there or gone? Or you left? Okay. Okay.